Sí, bien, empieza me decía mi esposo que son unos dolores parados.
Esto viene así.
Sí, sí.
Hello, John.
Chris, how are you doing today?
Fine, and you? Good.
Yep.
Uh,
You
Can
got a-
you
Go ahead.
include me as a co-host?
Yeah, sure.
I can help you here.
Profesor, buenos días.
Hey,
How you doing?
Professor
Oh, how
Salazar,
are you? Nice to meet you.
¿cómo anda la cosa?
Ah, bien, bien, todo tranquilo.
¿Todo bien?
Bien, bien, trabajando ahí bastante.
Está bien. Muy lindo el texto, ¿eh?
Okay, Louis, you can admit people and boot them out too. Although I've never seen I've never seen a
Okay.
reason for that.
Good. Let's see. Because Dr. Musi will be online soon.
Okay.
Okay, and he will start. I will call the people here.
Yeah, we got time. It's 10 minutes.
Okay, good.
Byron, when we're gonna shake up Ecuador again?
Yeah, I guess we're thinking of organizing something new in maybe next year, maybe
Okay.
January, March, something like that. So I'll keep you up to it.
Yeah, we're really gonna concentrate on Latin America, I think, in the next couple of months. Because I want to go first start with Latin America, then Africa, then the Middle East and the Southeast.
Perfect.
Hopefully to kind of concentrate on different areas. See if
Ah,
that
that's
works. See
very
if that
nice.
works. Yep.
Oh,
We'll keep you in tune what's going on. We'll
oh
keep
yeah,
you-
for sure. If you need any help, you
Yes,
just tell
you
me.
can
and
always
you
use
know that
speakers. Always use
I'm pleased
speakers.
to collaborate.
Have you been speaking
Actually-
about traveling at all or staying at home?
No, actually, we have a congress it's been done, I guess, in Miami. The minimal invasive congress and the brain tumor congress, something like that, I guess.
When is that?
I guess next month.
Oh, okay.
Yeah, I don't know if you're gonna broadcast it.
I don't know who's who is it depends who's televising it, who's running it.
Yeah, I'm gonna see who's coordinating that. So, maybe. it
Yeah,
would be
whoever,
to
I'll be glad to
broadcast it,
talk
right?
to. Yeah, whoever it is.
Make
I'll be
something
glad to talk to 'em.
online. Oh, I saw the other day all the webinar with Professor Atul Goel and the live sessions.
Yeah, he stayed all night one night. All
Yeah?
night. Yeah, I because I said, Atul, come on, that's nighttime. Your daytime is my nighttime. So I'm just staying up all night watching live surgery. But he promised, I said, is there going to be a commentator there? Okay. So otherwise it gets dull as hell. You're watching,
Yeah.
no one's saying what's going on. So they did it and it went well. The whole night. The whole night.
I was trying to see some of the video that was that I guess that was recorded, but I don't know why. it didn't come through. It just
No,
was like,
Yeah,
I don't
day
know.
one, day one, we had problems. The Tuesday, we did it okay. Where was the part you wanted to see? Monday?
No,
Tuesday?
actually, I guess it was the first day that they operated on posterior fossa tumor.
Yeah,
and
I
pituitary and something
unfortunately,
like that.
things screwed
Yeah,
up.
something happened because I was trying to see the once again because I stayed late watching the watching
Yeah,
the surgery,
I remember, I
but
saw
I
you.
wanted to replay it and I couldn't. Something happened with it.
I saw your name, yeah.
Oh, it was nice.
Yeah, we're gonna do it again because you can't get away with that in America, the live neurosurgery all night. Forget it.
Yeah, forget it.
The lawyers would love that.
Oh, but it was incredible. 5 hours, 5 different cases. Something that maybe only he can do it. For sure.
Yeah, have you been over there with him at all? Have you
There
been
we
with Goel, have you ever been over to Mumbai with Goel?
No, I haven't.
Okay. Your father has he ever there? Do you know?
I guess maybe he was. I actually I'm not sure.
Long time ago.
Long time ago, maybe. No, but it was nice, something very interesting. Different cases.
He's gonna do it. You want to see him again, right?
Yeah, for sure. Yeah.
You basically,
We could do something like that with Professor Borba also.
yeah, if he wants to do it, he wants to do it. You want to do
Cirugía al vivo, profesor.
neurosurgery, Louis? You know,
¿Cuándo hiciste? ¿Cuándo es? You did live surgery? Where?
Que el profesor Atul el otro día se mandó 5 horas de cirugía al vivo. 5 casos diferentes. Fosa posterior, una hipófisis, un tumor, una occipito cervical, fijación occipito cervical. Todo en 5 horas y diferente caso, y todo al vivo.
Sí, well,
It's good.
toda la noche. Yo estoy durmiendo. Estoy televisando. Estoy conectando primero. Yo fui a la cama y levanta a las 5 o 6. Y él está siguiendo en la mañana.
Están diciendo, ¿cuándo hacemos la cirugía al vivo suya, profesor?
Luis, ¿quiere televisar vivo? Cirugía vivo.
Oh.
He's not answering.
No, it's
too difficult.
Yeah, no, Dr. Antonio Musi, I don't know.
Not here yet.
Yeah, I know.
We got 3 minutes. Is the other speaker here?
He's trying. Where is he? Paulo Cadre was here, now it's out.
Is Keenan here? I don't see him yet.
Not yet, not yet.
Not yet. Okay, they'll get here.
Let's find where is Paulo.
Yes. Sometimes people like to cut it close. And we don't have to start exactly on at 7 or 8.
I'm trying to find Dr.
Do you have his phone number, Louis, or WhatsApp? Or?
Yeah, I'll contact him. He's trying to, I don't know what's going on.
Okay. Yeah, we could just start with one. Either one comes.
No, Doctor, yeah. We start with Dr. Musi, Antonio Musi. He's a great guy.
Oh, okay.
Where is he?
Kenan, are you in touch with Kenan?
Yeah, I can contact him. But Musi should be here.
Oh, Musi gonna be first?
Oh,
Okay, we'll just wait. They always show. Sometimes they'll come as another person. I won't recognize the name. Byron, are you presenting it for Sam's conference on the 15th of October?
yeah.
Yeah,
Invite the whole world.
He has 100 people. I think he's got 100 speakers.
yeah, it's like 12 hours straight, I guess.
Two nights,
Tonight.
12 hours. And we're gonna try to use that breakout room, Louis, so that after you talk, you get to go to a breakout room to talk to people and answer questions.
Ah, okay.
We're gonna try that because we need to increase the presenter's time. Because he's just got a quick 10 minutes and he's gotta go. But if we can give him a few more minutes with,
I guess he said that he wanted like maybe 15-minute talk. Oh, it was 10. I guess I thought
no,
it was
this is October 14th and 15th.
Ah, okay. No, well.
Yeah, let me just screen share here.
The people, some people, they're trying to open, they cannot. Yeah, Dr. Musi is trying to enter. I don't know what's going on.
Okay, let me see. You may have just,
Dr. Antonio Musi.
no. Not yet.
I don't know what's going on.
He's done these before, right? And
No.
He hasn't done it before?
No, he knows how to.
Oh, okay, because you guys could.
Dr. Guilherme also said link not possible.
Let me get, okay, I'll give you, I'm getting this right from.
Profesor, ¿y si le dice al profesor Musi que entre solo poniendo el código y le da el código,
No necesita código.
el número de la reunión?
Yo voy a dar, pero no necesita. Ok, yo voy al link, Luis, yo voy al link a ti,
Ok?
da a él. Ok, si él quiere código, yo voy a dar código.
Ok.
No sé si necesita, pero.
Hello, John.
Yes.
Can you listen to me?
Hold on.
Dr. Musi cannot get into the room.
I just, Guilherme, I just talked with him. I'm sending the link to him.
Okay.
Yeah, Louis, I'm going to give you the web ID, webinar ID, which he shouldn't need, but give it to him anyways. Because all of us got in without that.
Maybe if you have a meeting ID, I can send to him too.
Já enviamos, cara.
Não, beleza, que ele não respondeu, mandou que tava dando errado ainda.
Alguém mais não conseguiu entrar?
Oh, okay, there he is. Okay. He's here.
Oh, yeah. Yeah. Let's promote him.
Yeah.
Okay, good.
Okay, Louis, you're moderating, right?
Yeah.
Okay.
Hello.
Hi, Dr. Musi.
Oi,
Hello.
Antônio.
Oi, Borba.
Tudo bom? Agora consegui.
Aí, que bom.
Are you ready? Are you ready?
Yes, I'm ready.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3. Good evening. This is Dr. John Bennett broadcasting from beautiful Miami Beach, home of Neurosurgical TV. We have another grand rounds of Mackenzie Hospital in Curitiba, Parana, Brazil. We're being hosted tonight by famed educator Louis Borba. Welcome, Louis. It's all yours.
Okay, thank you very much, John. And thank you for the opportunity. Thank you to help us to transmit all this education program to the whole world. Today is a very special day. We have two very distinguished guests. The first is Dr. Antonio Musi. He is a Brazilian neurosurgeon that trained in São Paulo, and after he did his fellowship, University of Kansas with the professor Albert Rotten. Now he's working in the beautiful city and beautiful island of Florianópolis in south of Brazil. Thank you very much, Musi, for joining us. Dr. Antonio Musi, you talk about the surgery and anatomy of the Pioneer region. His work in Gainesville at that time is recognized around the world. And thank you very much for joining us in this webinar. Thank you, Musi. Please go ahead.
Let me see here. New share. Let me see. Okay. Is it appearing?
Perfect. Yeah, perfect.
Yeah,
Perfect.
it's perfect.
Okay, first of all, thank you, Dr. Borba, and all the organizers for the chance to participate in this meeting. I will talk about the microsurgical anatomy of the pineal region and paying attention especially to the anatomy of the approaches to this region. What are the difference between the most important approaches to the pineal region, and how do we select the best approach for a specific lesion? So the pineal region, the pineal gland, is located in the posterior part of the third ventricle, and it is limited superiorly by the splenium of the corpus callosum, and laterally it is related to the pulvinar of the thalamus, and it is located just above the quadrigeminal plate. So it's a deep region, and that's why also with many vascular structures, mainly the veins, the deep venous system, and that makes it challenging region for surgery. So let's look a little bit of on the anatomy of the third ventricle and how it's related to the pineal, because most of the tumors in the pineal region, they go inside the third ventricle. So when we look from above, we see the lateral ventricles. The most superior portion of the roof of the third ventricle is the fornix bilaterally. So if we remove the fornix, we see a layer of tila choroidea that goes laterally to the choroid plexus on the lateral ventricle. There is another layer, deeper layer of thylakoid that goes to attach. This is the second layer of thyla that goes to attach on the lateral side of the thalamus. And between these two layers of thylakoid, we have the internal cerebral veins and the medial posterior choroidal arteries. So these structures are on the roof of the third ventricle. This is the attachment of the inferior layer of thyla. This inferior layer attaches from the foramen of Monroe laterally to the thalamus and above the pineal gland. It attaches here above the pineal gland. So this makes the so-called suprapineal recess. And it is through this recess that we gain access to the third ventricle when we come from posterior. So this is a sagittal cut along the third ventricle, and we see this attachment of the inferior layer of thyla. These are the structures forming the roof of the third ventricle. So we see this attachment of the inferior layer of thyla and attaching here to the superior side of the pineal gland. Just above the pineal, we see the vein of Galen and the splenium of the corpus callosum. So when we look from anterior, we see the suprapineal recess, and the pineal gland is attached to the posterior part of the third ventricle by two structures. The first one is the abennular commissure, and the second one is the posterior commissure. So when we gain access to the third ventricle coming from posterior, we come here above the pineal through the suprapineal recess. So we have two main access to the pineal region. We have one access above the tentorial, the tentorium, and another access inferior to the tentorium. But when we talk about the pineal gland, and the pineal gland is in the quadrigeminal cistern, we have to make an observation that we have also access to other structures near the pineal region. For instance, here we can see the continuation of the quadrigeminal cistern with the ambient cistern. So just lateral to the ambient cistern, this portion here is the posterior part of the parahippocampal gyrus. Also, we have access to the posterior part of the brainstem. Also, we have access to the posterior part of the interhemispheric fissure. So all these regions can be also exposed in approaches to the pineal region. This is an example of the medial side of the brain. So pineal would be here, the thalamus, the splenium of the corpus callosum. So all this region here will be exposing posterior approaches to the pineal region, including the posterior part of the parahippocampal gyrus, the lingual gyrus, the cuneus, the precuneus, and also the posterior part of the interhemispheric fissure and posterior part of the cingulate gyrus. So all this region also can be approached. We see here with the dura mater, and this is, again, this is going to be the cuneus, precuneus, and this is going to be posterior part of the parahippocampal gyrus. And we have here also the straight sinus on the midline. Another point to remember is that when we go infratentorial, we are dealing with the tentorial surface of the cerebellum. And the tentorial surface of the cerebellum has its highest portion in the midline, the cumen, which is this portion here. As we go laterally, it goes down. So whenever we come more laterally, we'll have a better view of the quadrigeminal cistern than when we go along the midline. This is an illustration. So here's the cumen. And as we go more laterally, we can have an advantage of this slope of the tentorial surface of the cerebellum and expose the quadrigeminal cistern. Here we can also see the lateral mesencephalic sulcus, which also can gain, we can gain access to the mesencephalon from approaches to the pineal. Now, the most difficult structures that we have to deal when making access to the pineal region are the deep venous structures. And here we have an illustration of the course of the basal vein of Rosenthal. So it goes around the brainstem, receives branches from the roof of the temporal horn, another branch here from the lateral mesencephalic sulcus, and it drains here to the basal to the vein of Galen. Another vein is on the roof of the third ventricle. We already saw it's the internal cerebral vein. Here, the thalamostriate vein draining to the internal cerebral vein, and also veins that drain the medial side of the atrium that go to this region. So we see the complexity of the venous structures around the pineal gland. Another view of the basal vein of Rosenthal, receiving here a vein from the temporal horn, another vein from the lateral mesencephalic sulcus, and another vein that goes along the midline, which is the precentral vein, goes from below upwards to drain to the galenic system. So this is the precentral vein, or also called the vein of the cerebellomesencephalic fissure. And when we come from below, usually this vein is coagulated so the cerebellum can fall down and improve the access to the pineal. So now I will show the view that we have from the two main access to the pineal region. This view was done in the same cadaveric specimen. So you will see the same structures from different angles, from superior supratentorial and from inferior infratentorial. So this is superior. This would be an occipital craniotomy on the lateral side. The occipital lobe is being elevated. So we are seeing the posterior part of the splenium of the corpus callosum, the falx, the tentorium, straight sinus here, galenic vein, basal vein of Rosenthal. So this is going to be the calcarine sulcus. So we see the posterior part of the parahippocampal gyrus, continuing here with the lingual gyrus, and we see the posterior part of the cingulate gyrus. So when we do this access, we have the venous structures more or less in the middle of our view. We see the two internal cerebral veins, we see the splenium of the corpus callosum, the pineal, and we see the basal vein. We can complete this access by cutting the tentorium. Then we have a view of the tentorial surface of the cerebellum, and we have a better view of the quadrigeminal plate with the pineal gland. This is going to be the precentral vein. This is vein of basal vein of Rosenthal. So this is the pineal, again, quadrigeminal plate. So this is the view occipital transtentorial approach above the tentorium. One of the main characteristics of this approach is that we have a very good view above the vein of Galen, which we will not have when we come from below. We also have a good view of the parahippocampal gyrus. Again, the calcarine sulcus is up here. So all this region here is going to be the parahippocampal gyrus with the posterior cerebral artery and its temporal branches coming here. So we can also access tumors located on the posterior part of the parahippocampal gyrus. And this is the course of the basal vein. And as I said, we have a very good view above the galenic system, and including here the splenium of the corpus callosum and the posterior part of the cingulate gyrus. Now, when we go infratentorial, we can have a midline approach or a paramedian approach if we go more laterally. I will talk first about the median approach. So this is going to be the same anatomical structures, but now seen from the angle from below. So this is going to be the precentral vein. This is the vein of Galen, basal vein on this side, basal vein on the other side, and the internal cerebral veins. This is the pineal, so this is going to be the suprapineal recess. Here we can see the internal cerebral vein going together with the posterior, the medial lateral posterior choroidal artery to the roof of the third ventricle. So this is the suprapineal recess. If we open here, we get to the third ventricle. And this is the precentral vein that is usually coagulated so the cerebellum can fall down and gain in order to gain more view of the quadrigeminal plate. This is the view that we get from below. So you can see that this is the splenium of the corpus callosum, but it's going to be much harder to expose above the galenic vein, as we saw from the approach above the tentorium. So we see the splenium of the corpus callosum, and this is the suprapineal recess. Suprapineal recess open. What are the advantages of going infratentorial and midline? First, you have a bilateral view of the structures. It's more easy anatomically because we are not coming from one side. We see both basal vein of Rosenthal on the two sides, and we have a direct view to the third ventricle. Another advantage is that usually tumors in the pineal region, they are going to displace the venous structures upwards. So when we have this access, we get directly to the tumor. So we can do a debulking, and then we are going to see the venous structures. These are the advantages. If we open the tentorium, just to give you an example of our anatomical direction here. This is the calcarine sulcus, so this is going to be the posterior part of the cingulate. So it's very hard to expose from below above the galenic vein. This is the galenic vein. And this is the same view bilaterally. Now, if we come more laterally, also called the paramedian approach, then we have this advantage of the slope of the tentorial surface, and we can come from more lateral and have a better view of the quadrigeminal plate. Of course, we can combine the paramedian approach with the median approach. This is just to give you an example. We can also open the tentorium from below and get access to the parahippocampal gyrus. So this is going to be the parahippocampal gyrus. The calcarine sulcus is up here. So this is all, this region here is parahippocampal gyrus. And we also can gain access here easily to the lateral mesencephalic sulcus if we have a pathology on the mesencephalon. So this is going to be the lateral mesencephalic vein and the basal vein. And you can see the complex of the venous structures in the pineal region. So we have a better view of a good view of the quadrigeminal plate. And now let's see some surgical examples illustrating this anatomy. So this is a tumor of the pineal region on the inside the third ventricle. We could come to this tumor either from superior or from inferior. Many times it's more a choice from the surgeon, but the infratentorial approach gives us some advantages like the bilateral view, and also the cerebellum falls a little bit more, and we have direct approach to the tumor and the third ventricle. So many times, for my choice, I prefer to go infratentorial. as in this case, this case we did infratentorial approach. And so you can see exactly the same as we were looking to the anatomy. So we have direct view of the tumor, and we are dissecting the arachnoid, and the precentral vein is here, located to the tumor, so we can coagulate the precentral vein or the vein of the cerebellum mesencephalic fissure, and we proceed to debulk the tumor, and the venous structures are going to appear in the end upwards. Here we start to see the splenium of the corpus callosum. Then after debulking, we can see inside the third ventricle. And after removing the tumor, we see the thalamus, the choroid plexus on the roof of the third ventricle, foramen of Monro, the fornix, and everything from below. And so this is, you can see that the tumor retracts the venous structures upwards. So this is going to be the basal vein on both sides. And after removing, here we see the massa intermedia inside the third ventricle. Again, here with the internal cerebral veins and the postoperative result. Now, this another tumor in the pineal region, but how are we going to define which is the best access in this case? In this case, if we look, there is a cyst. The tumor is more inferior located, maybe related even to the brainstem. So it's not really a pineal tumor, but in the region of the pineal gland. So in this case, we chose to go infratentorial. So we see the combing again, and we are going to see the tumor laterally located. I'm not going to pass everything, but just coagulation of the precentral vein. Then we can see the tumor located to the mesencephalum laterally here, and proceeding with resection, and we can see up here the venous structures. So all this was tumor, and this was an ependymoma. So this is what this is a ependymoma of the mesencephalum. Just to show the resection here. After resection, we had a cyst, and the tumor was completely removed, and this is the operative result. So this lesion was located in the posterior part of the brainstem. Another tumor in this region, not pineal gland, but also approaches to this region. So this was a mesencephalic tumor. We decided to approach through the lateral mesencephalic sulcus using exactly the same approach, but in this case, we opened just on one side, the paramedian approach. So this is the tentorial surface of the cerebellum. Always we drain CSF below, so the cerebellum can fall a little bit more. And then we proceeded directly to the brainstem. We used neuronavigation and monitoring. So we opened the mesencephalum and removed the tumor. This is the postoperative result, and this is the CT. This is just to show some examples. Now I've shown the infratentorial approach to the pineal and also to the region near the pineal. The last example, this is a cavernoma of the mesencephalum. Also, we can come here through the lateral mesencephalic sulcus, exactly the same approach, removing the cavernoma and the postoperative result. Just to illustrate. Now I'll go in supratentorial. So supratentorial, it's very important to remember this anatomic relationship. Always we do posterior occipital and occipital craniotomy, where the superior burr hole is going to be located in the junction of the lambdoid suture. The junction of the lambdoid suture points us also to the lateral, to the parieto-occipital sulcus. And usually we have a vein draining exactly on this region. So we have about 7 centimeters below the junction of the lambdoid suture, where we have a completely free access to the pineal region here. Usually we don't have veins here, just this vein coming here. So if we do this craniotomy in this region, and also the sagittal sinus is not difficult to dissect and does not bleed so much as it bleeds when we do parafrontal craniotomy. So it's much easier to do this approach from posterior. So we are going to do the upper burr hole here. So we expose this region, it's very important to expose the sagittal sinus. We open the dura like this, and this is a very constant anatomy. We are going to see this vein draining exactly on the upper portion here, near the junction of the suture, and we have all this free corridor here to go. So we go elevate the occipital lobe, and then we can open the tentorium. Now, this opening of the tentorium, it's best not to open directly parallel to the straight sinus, because we can have venous structures near the sinus. So the best way to open is from more laterally, going this direction. We open the tentorium like this. So the positioning, the patient is 3/4 prone, and the side that we are going to operate is below. So by gravity the brain falls, and we have this access. We can do a straight, or we can do like a U-shaped incision, the craniotomy. And this is just like the anatomical specimen, with the vein here draining on the upper portion. And we have this opening the tentorium. We can see the straight sinus, the falx, and the tentorium. So this is just to show how to open the tentorium. In this case, we can either, the straight sinus is here, so we do incision like this, and then we can pull this with a stitch, or we can just cut this portion of dura, and then we have this exposure of the quadrigeminal plate. We can see here, we can open a little bit more, and we have this exposure of the quadrigeminal plate. You can see here, opening the quadrigeminal plate, and we can see already the precentral vein here, and we dissect all these structures here. So this is just to show the illustration of this approach. Now, this small tumor, this was a child, so we decided to do going upward, so occipital transtentorial approach, because it's much easier to position the child, and it's a small tumor. We decide to do this approach, and we can see again, this is the straight sinus. We open the tentorium like this, so we can see the quadrigeminal cistern, opening the quadrigeminal cistern, basal vein of Rosenthal. The tumor is going to be here. You can see the basal vein. This is the cerebellum, this is the tumor, and this is the mesencephalum. You can see tumor here and mesencephalum here. So we can proceed with the resection. And we open here already the third ventricle. And we can see after resecting the tumor, and we can see the thalamus on both sides. One of the problems with going posterior is that if the tumor goes anterior to the splenium of the corpus callosum upwards, it's going to be more difficult to go from supratentorial than infratentorial. But this was a teratoma, it was completely removed. This is another tumor on the pineal region, but as we look to the sagittal side cut, what do we see here? We see a tumor that is located above the galenic system. We can see clearly here above the galenic system. So this tumor, we cannot go from below. We have to go from the occipital transtentorial approach. This was a glioma of the splenium, in the splenium of the corpus callosum. This is a tumor, this is a metastasis located on the posterior part of the parahippocampal gyrus. So this we can also do exactly the same approach as to the pineal. We can come from posterior and we can completely resect this tumor. Exactly the same craniotomy. This craniotomy can be used for many different pathologies, like an AVM. This is an AVM located on the parahippocampal gyrus. We can also come occipital transtentorial approach and remove this AVM. And this is the post-operative result. This is showing here the parahippocampal gyrus. Another case, this is a glioma located on the posterior part of the cingulate gyrus, and we can see just posterior to the splenium of the corpus callosum. We can use exactly the same approach. This is showing here the tumor, the location of the tumor. So posterior part of the cingulate gyrus, as we saw exactly in like the anatomy. So we can come here and remove this tumor, occipital transtentorial approach. Another tumor. This is a 40-year-old woman with this tumor, just headaches. And if we see the coronal cut, again, above the venous structures. So this tumor, we cannot come from below. We have to come from superior. This is location. You see the splenium of the corpus callosum, region of the pineal region, but again, above the galenic system. So we chose to go from the occipital transtentorial approach, and this was a meningioma, falcotentorial meningioma. Another case, a huge tumor, pineal region. If we look, it also comes from more upward, and we can see above the galenic system. So another choice for the supratentorial approach, occipital transtentorial approach. Exactly the same craniotomy, how we do the craniotomy. So 4 burr holes, exposing, you can see that the sagittal sulcus is easily exposed. And we open exactly the same, the venous structure draining here on the upper side. So in this case, we can open also the falx and gain access to the tumor on the contralateral side. So this is on this side, and opening the falx to get access to the tumor on the contralateral side. So we open here above the straight sinus, and we get to the other side. And then we can have the occipital lobe on both sides and the tumor completely exposed. And we can remove the tumor like this, and both sides here, the vein here, and completely remove the tumor. And finally, another case using exactly the same approach, the occipital transtentorial approach, but this was a child, with a tumor inside the atrium. So this interhemispheric approach is very useful to avoid coming laterally and damaging the optic radiation. So we can come from midline, exactly the same approach. So we are going to come here, opening parallel to the splenium of the corpus callosum and getting access to the atrium. So this is the splenium of the corpus callosum, posterior part of the of the cingulate gyrus. We do an opening here more laterally than the splenium of the corpus callosum, and then we get to the atrium and remove the tumor. This was choroid plexus papilloma, and we can see inside the atrium, we can see the thalamus on one side and the fornix in the other side. And another advantage of coming from the midline is that we have directly access to the choroidal fissure. And so we can go and coagulate all the vessels that are going to the tumor here and remove the tumor. This is a showing how very quickly, so just parallel to the splenium of the corpus callosum, of course, we can use neuronavigation and exposing the tumor, coagulating the tumor. So this is inside the ventricle. And you can see that we are using a little bit of the spatula here, but removing the tumor, choroid plexus. Let me go a little bit further. And then we get access, coagulate from the choroidal fissure and remove the tumor. And here, a little bit of attachment to the choroidal fissure. So we coagulate this and completely remove the tumor. And here we are inside the atrium, and we have a very good exposure of the atrium coming from midline. So, and this is the result showing exactly how it was done. So I thank you again for the chance to participate here. And I think we have reviewed this region, not only for pineal tumor, but also for tumors located in this region. Thank you very much.
Thank you, Antonio. Thank you. Wonderful presentation, wonderful anatomy. Very difficult case, you know, some very interesting to see the approach that you, the selection of approach. When you use one approach, you use another approach. Let's open to the panelists who have 20 minutes that you can discuss something. You have here Dr. Paulo Cadre, Dr. Byron Salazar, Professor Ken Arnautovic, Juan Luis Gomez Amador. They can ask something to Antonio Musi. I will start to ask him about this tumor in the atrium.
Mm-hmm.
It was not difficult to see the angle like that.
No,
you see,
no,
we did lateral because the supratentorial approach, the transtentorial approach, the most difficult is the homolateral side, not the contralateral. The homolateral, when you see in this direction, like
of course,
in the ventricle was not so big.
We did very recently a bigger meningioma, atrium meningioma. The patient didn't have no deficits prior to the surgery, and it was he even had the edema, and we could remove doing a debulking. As you do the debulking, the tumor comes and we can see everything and coagulate, and it was very, very good. The patient didn't have any deficits, and just doing exactly the same approach.
Yeah, excellent. The choroidal plexus tumor is a bloody tumor, no? It may, sometimes it's more difficult to, it has to go around first, but wonderful. Byron Salazar, want to say something?
Thank you,
Please,
Professor.
Byron, go ahead.
First of all, congratulate Professor Musi. As always, an excellent lecture, amazing images. I had one question. The first two cases, when you did the supracerebellar infratentorial approach, I saw that the tentorial angle was very steep. So I don't know, maybe maybe in your case, I don't know if you did it with in the semi-seating position, because I saw that you had a lot of nice exposure. And sometimes when we got this stiff angle, we prefer to go occipital transtentorial approach. When do you like the semi-seating position for those cases? Would you recommend it, or you can do it in prone position? And another question would be, do you have any experience in the occipital interhemispheric approach? Would it be like something that you would consider for some of your cases? Thank you.
I think when you have a tumor in the pineal region, you can go either from above or from below. Many cases, it's going to depend on the experience of the surgeon to decide. I myself, whenever in an adult patient, I prefer going infratentorial because I think the cerebellum falls down more. We have a better view both sides at the same time. I myself prefer to go from below, and that was the case. But for instance, a small child, the other case is more difficult to position, so we decided to go occipital transtentorial. And I know surgeons who prefer going mostly for most tumors to go occipital transtentorial. One of the problems of the occipital transtentorial supratentorial is sometimes it's more difficult to see also when the tumor is very attached to the venous structures on the roof of the third ventricle. It's more difficult to dissect when you go supratentorial than when you go infratentorial. So I think you have a better view of the third ventricle going infratentorial also.
Thank you, Professor.
I mean, the line is midline. Yeah?
Yes.
You can see everything. Midline is midline. Yeah. Paulo Cadre, want to say something? How to approach the thalamic pulvinar from the? Is better from the side or from the middle?
For me?
Paulo, for you. For both. For Musi, for Paulo. For the thalamic pulvinar that is coming in the lateral here. Think it's better coming from the midline or coming from the side?
I think I would go supratentorial, occipital transtentorial approach. I think it's easier to approach for the thalamic tumor.
I would say that if the tumor goes below the splaining of the corpus callosum, going from above, it's very difficult to get in that region. So it's better to go from below. On the other side, if the tumor is going really down, so I prefer to go above the tentorial, because when you cut the tentorial, you have a straight look more down. But I was going to say, as always, Musi, it's always beautiful to see your pictures and your presentation. Thank you. Thank you so much. I'm really missing you.
Nice to see you again.
Professor Arnautovic, you are listening to Dr. Musi.
I enjoyed this.
More you see anatomy, more beautiful is the picture.
Fantastic presentation of Professor Musi. I really enjoyed. One of the things, since you asked me to chime in, I want to ask Professor Musi. You know, in the United States, it's very difficult to convince anesthesiologists to do sitting position. And no matter how good you are, and I'm not as good, obviously, with this huge series that you have, and I learned the tricks from Professor Turli and Professor Yashargil and Evandro de Oliveira released CSF at the foramen magnum, and the cerebellum will fall down. But in the prone position, it never falls down as beautifully as in the sitting, obviously. Yeah. Do you have any tricks for us who cannot convince our anesthesiologist to go into sitting position? Depends on the anesthesiologist, you know. How can we increase this space on the paramedian approach?
I think very good question. I think always when you go same sitting position, the cerebellum is more relaxed than when you go paramedian supratentorial transtentorial approach. Even opening widely the cistern, and that's why just for pineal tumors and lesions around the mesencephalum, I prefer going same sitting position, because I think you get much more relaxed brain than coming from lateral position. and supratentorial. I don't know how to get as a relaxed as from supratentorial as infratentorial, same sitting position.
If I can make a comment, you know, I never tried, but I saw Professor Almefti doing, because he also has the same difficulty as you have, Kenan, to put the patient in sitting position there. So what I saw him doing for those lesions, it's putting the patient not in straight prone position, but also kind of 3/4 prone. So you get the advantage also to go a little bit more lateral in the paramedian. And somehow you have a more, the cerebellum goes a little down and more towards the other side. I never tried myself, but I saw him doing, and I said, yeah, that may be a way to take a little bit of the advantage also of putting the patient not in straight prone position.
Let me show something here, just to end. Can you see my picture here? Can you see the?
Mm-hmm.
Look at that. When you do sitting position, your hand will be like that, very long. Look, this view, when you have and you use the exoscope, this patient is in sitting position. You are doing you are using the exoscope. We see how comfortable you are doing a sitting position. In this case, also a supracerebellar approach to a thalamic tumor. A child also there in Russia that we did 3 years ago with Professor Sufyanov. It's very interesting that how comfortable it is to do a sitting position. The patient, of course, sitting position using the exoscope. I think this will be a good advantage. One of the indications of the use the exoscope that in this situation can replace the microscope. We don't have the exoscope here very often, but you can see that it's much more comfortable than to do the sitting position. It's the hand like that. You see, it's makes it. And now that the microscope is coming with the head like that. The light is. This microscope is getting bigger and bigger and bigger. It should be smaller and smaller and smaller to make it more comfortable. See, and now it's getting bigger. I don't know why it's making more difficult. This guy, I don't know if Kenan has some experience with exoscope in cranial or in spine to use the exoscope.
So first of all, I'm going to report your usage of exoscope to Dr. Almefti, okay? So you'll be
no, exoscope, not endoscope. Exoscope.
No,
exoscope is good.
Second,
endoscope also is good.
I never tried exoscope. I probably you guys have, but in my mind, it's like driving Formula One, 250 kilometers an hour and watching the screen, not watching the road, watching the screen. In my brain, it's a little difficult to combine all these projections. I don't know. Probably my brain is much simpler and stupider than yours,
No. Before do that, I was thinking the same way. But it's very easy to adapt. It's crazy. It's crazy, but it is very easy to adapt to the exoscope. It's making propaganda now. This is the new exoscope that I'm sure is developed. That it's not to every case that people want to use. But there is some situation that the exoscope is really very good. I think in sitting position, it's helped a lot. It's much more comfortable for you, for a patient in sitting position. Let's see the future is coming. Exoscope, endoscope, microscope, everything that is scope, but always microsurgical technique. This will make the great difference. I don't know if you have question here from the audience. Maybe you can. Thank you, Antonio. Thank you for the wonderful lecture. I really appreciate it. Maybe you come back soon to talk about. He has so many beautiful anatomy, so many areas that he's doing a wonderful job here in Brazil. That soon you call again. Thank you very much.
Thank you.
Okay, let's continue our ground round today with our friend, our mentor, Professor Ken Arnautovic. Ken Arnautovic is a neurosurgeon from Bosnia. He trained in Bosnia. He trained in US. Today, he is professor of neurosurgery, University of Tennessee. He has a great experience in skull-based tumor and brain tumor. No, his institution is one of the busiest institutions in the whole US. I think more than 4,000 or 5,000 cases a year, maybe more now. Okay? And more than that, he's also a guy that is the chair of the ALK Committee of the World Federation, and he's driving this education around the ALK Committee. And what Kenan is doing the last 2 years is very, very impressive. You see, it will be marked for the future. Please, Professor Arnautovic.
Good afternoon, good evening, good morning, depends where you are in the world. Can you hear me and see my screen?
Yes, perfect.
Yes, you can hear.
Okay. So first of all, I would like to thank Luis Borba, my friend of, I think about 31 years or something like that, who is, and I'm not saying this to return the compliment, but he has been really person that I look up in education in neurosurgery. First, I learned from him watching his videos. Second, I learned from him how he energetically organizes the education around the world. He will sit in an airplane and go anywhere in the world to give a seminar and teach all of us about beautiful surgeries. And he has really done a beautiful job leading the education committee. And I really appreciate that. And of course, you know, Latin American neurosurgeons, it's a place where I go very, very gladly. I have probably about 150, 200 close friends in all countries in Latin America, all of you in the panel, the people that I trained with Professor Al-Mefti and others, and I'm really pleased to be here. So I'm going to talk today about hemangioblastomas of the central nervous system. I have been interested in neurosurgery. This has been one, gather some cases over the years, and then kind of employed my residents and fellows to do some research, because when I study a subject, I want to understand it completely from all different aspects. So I'm going to talk today about it, show you a few cases, and then if you have any questions, I'll be happy to. I don't have any disclosures, and these are my fellows and colleagues and residents who worked on this many projects with me. I published in different journals different topics about hemangioblastomas, and to tell you the truth, I've learned more with the research of my fellows than I taught them in this process. So as you all know, hemangioblastomas are rare tumors. Yeah, you know, we don't see them very often, and they come only about 1 to 2% of all intracranial tumors, and about 7-8% of all posterior tumors of the cranial fossa. They arise from cerebellar hemispheres most commonly, so they are very common in adults, more common than other places. And they are believed to be more common in males than in females. And then single tumors appear more common in general population, but multiple tumors almost always with von Hippel-Lindau disease in 33%. So what is von Hippel-Lindau disease for residents in the audience? It is, of course, hereditary condition located on mutation on chromosome 3. And as we all know, when we get a patient with hemangioblastoma, we look for retinal angiomas, very dangerous situation. They can become blind. And then also they may have clear cell renal cancer. We need to look on CT scan, chest, abdomen, pelvis, more rare pancreatic and neuroendocrine tumors, and some other tumors, as well as cysts in the abdomen. Obviously, this is very, very dangerous disease, and we need to understand and know everything about location of different lesion in people, in patients. So this is one of my favorite. Whenever I look something, I first look how often was it published in the world, and you can see here as the time goes on, there are more and more publications coming on this topic, like in many other topics, and you can see by years all this publication. And we looked differently on supratentorial location, infratentorial location, and spinal cord. So which countries published most? And this is also a very interesting subject. Obviously, United States is leading by these publications, and then followed by Japan in all three locations. And then you have also Germany, United States, and China, and all that. Now, always first question, they ask me, is it because United States publishes the most articles, or it's because there are the most patients in the United States, or it's because it's most populous country? And I don't know the answer. I don't know the answer, and I hope one of the junior colleagues are going to look into this closer. So continental distribution is very similar. Obviously, Asia, Europe, and North America leading the publication when you look into continent. Of course, when I say Asia, I mean, combined, this is Japanese and Chinese and others. So then they take over North America and Europe in all locations. So this is another thing that we look, the ratio of male to female. Obviously, you can see here, first male to female, supratentorial, infratentorial, spinal cord. And you can see here that females are more common in supratentorial, and of course in infratentorial males, and then spinal cord males. But then you have von Hippel-Lindau and sporadic ratio, and you can see here that the sporadic hemangioblastoma winning in brain location and spinal cord, it's reversed, and mean age is about 40 years. And then locations, you can see all kinds of different locations in the brain. You can see where the most common, obviously, infratentorial cerebellum. In the supratentorial, you see them everywhere, but cellular, paracellular, and temporal appears to be most common. And then in the spine, it's cervical spine. And you can see all kinds of different location, intramedullary, extramedullary, combined, and so forth. Now, distributions of symptoms here, just for you to understand, von Hippel-Lindau is inner circle and sporadic hemangioblastoma outer circle. And you can see the symptoms in the brain are always raised intracranial pressure, whereas in the spine, obviously, they are most commonly pain and motor deficit, which is understandable as they cause cysts, as they have multiple, hydrocephalus and other reasons to have increased intracranial pressure, whereas in spinal locations, it's mostly pressure. So, and this is one of the things, before I looked into this and before I started gathering experience, I noticed that everybody talks about a big cyst and then a nodule, and then you take a nodule out, cyst collapses, tumor is gone. Well, it's absolutely not true. If you can look into this slide and see that cystic with mural nodule in supratentorial location is only 11%. So all other types, and there are 4 types, solid and cystic combination, cystic with mural nodule, and cystic, they are obviously more common than just one that we traditionally thought before we looked into this are most common. And then obviously infratentorial locations, again, solid is most common as opposed to what we thought conventionally. So one of the things, and I'm not expert in pathology, these are the proteins that you use most commonly. Obviously, vimentin, S100, and NSE are the CD34 most commonly used stains to diagnose these tumors. Resection rate, this is also very interesting. As we go down, resection rate increases. supratentorial only 79% gross total resection. And then if you go lower cerebellum, spinal cord, it goes up about 5 to 10 points. That's also very interesting. Now, this is kind of eye-opening distribution of hemangioblastomas complications. You can see here that despite a lot of people reporting no complications, there are a lot of different things in about 1/4 of population or patients, and supratentorial 10%, infratentorial 40%, and spinal cord 7%. So infratentorial location is very, very serious because almost every other patient, according to reports, will develop some problems. And look at the blood loss. You have to be ready because even with the spinal location, 300 cc's, here with other locations, 600 to 700 cc's, pretty big blood loss. There is distribution of treatment outcomes. Most commonly, about 2/3 to 3/4 of patients do well, but 10% of them died in the infratentorial location, 4% in supratentorial, and 5% in spinal cord. So this is eye-opener. I mean, you have to tell your patients there is a risk with this. So based on this multiple reviews that we did, we can say that the number of publications has significantly increased in the past 21 years. Obviously, Asia has most articles, followed by Europe, but US leads by number of publications by country. Tumors come most commonly in 5th decade of life. Sporadic tumors are more common in cranial and von Hippel-Lindau in spinal locations. Most patients get gross total resections, and favorable outcome, as I said, is about 3/4 of the patients. But complication rate is high, and mortality rate reaches about 10%. So one in 10 patients may be expected to die with this problem. And as I mentioned, infratentorial location. And then in the cranial locations, blood loss is very high. We need to be ready. So let me just show you some clinical cases that I encountered out of my series. This is 53 years old with balance problems and headaches. You can recognize them by this is solid type, obviously. As I said, they are most common. And you can see here that they have flow voids inside. And I learned over time, it's pretty clear that this is hemangioblastoma when you see this amount of flow voids and significant amount of swelling around it, or it raises significant possibility that this is hemangioblastoma rather than metastasis or meningioma or some other tumors. So I'm just going to show this case. This is obviously right side. And what you need to understand in these tumors, they are like AVMs. So they drain into in this location to the transverse sinus. So I'm starting dissection very inferior, just at the lower aspect of the tumor. And I go from the inferior portion to the lateral portion. And then gradually, after decortication, every coagulation of this PL blood vessels would contribute to decreased vascularization. But never go first to this big vein that drains into superior sagittal sinus, because like in the AVM, you will have a disaster. So keep it till the very end. So here I'm vascularizing and decorticating the tumor right at the edge using stealth nerve navigation and slowly developing a plane. As you approach to the cranial location, the superior location, you will find out that the vascularization becomes more abundant, and this is the danger. You saw how much blood loss there is. So you really need to go very slowly, coagulate blood vessel by blood vessel. The problem compared to AVMs, in AVMs, you can see blood vessels that are contributing. You can slowly dissect them and coagulate. Here, you don't have a blood vessel per se. These are more arterial lakes that vascularize the tumor. And it is not, it's similar to AVM, but it's different because you cannot isolate these blood lakes very well like you can do in AVMs. You see, this is one of these arterial blood lakes, and you need just to stay there, don't leave the spot, keep coagulating, keep hemostasing, and you can use some gel foam if need be, but do not panic, do not allow a lot of blood loss. Just stay with the bleeding and control it. And as you see, eventually you're coming around the tumor. Again, this is the last part. This is the venous drainage, but obviously the blood vessels are interrupted, and here we are coagulating the last parts of the tumor. Here is the final coagulation and removal. And then looking into the walls, looking into the basically raw surface, and doing hemostasis, making sure. Because if you don't do the precise hemostasis, obviously, as you saw, very high rate of rebleeding can yield with postoperative bleeding in the middle of the night and problems. So this is the patient after surgery. You can see gross total resection. Another case, this is the patient, this different type. This is combined cystic and solid. Solid part is in the wall of the tumor, cystic part is inside. But this is also very bloody tumor. You have to come around and be very careful. You have to have appropriate exposure because the tumors always like to be around the transverse sinus. So you want to have a good control, good exposure, and good dissection plane, both proximally and distally of the transverse sinus, as well as exposure of the transverse sinus for, God forbid, situation, just to be able to control and do hemostasis with these big veins that go into transverse sinus. So this is postoperative. The other case, this is the classical case. This is the case that you have a nodule, and this is the easiest case, and the big cyst. You come in there, you resect the nodule, only that little nodule, the cyst collapses, and that's complete cure. The other thing that I always use in posterior cranial fossa is this fat pad that I learned from Dr. Almefti. All my cases of Chiari, posterior cranial fossa surgeries, spinal cord tumors, I use the fat that I harvest at the beginning of surgery from the belly, because belly fat is much softer and it better conforms to the allotted space. And I'm still waiting for my first spinal fluid leak with posterior cranial fossa tumors, spinal cord tumors, also pituitary tumors. I'm really eager to see one. It has been 20 years. Another case, also posterior cranial fossa. This is also on the other side than the one that I showed you. You can see significant swelling. Sometimes you think that this is metastasis, but what gives it away is it multiple flow voids in the tumor. You can see, and you know that this is angry tumor. And you can see here, there are some blood vessels. Those are this arterial lake blood vessels that go into the tumor. They're not like in AVMs. Again, I'll emphasize that a single blood vessel, you isolate it, coagulate it, divide, you are done. No, these are more lakes in this certain location. So by analyzing these images, you know before surgery where is the danger, where is the trap. Another case, this is lady, they can come also in small size. We caught this one early and took it out. But even the small tumors tend to bleed. So one thing that you don't want to do, you don't want to get into the tumor, even the small tumor, you want to go around it, devascularize it, because even the small tumor can cause significant bleeding. The spinal cord, this is the case that I published in Operative Neurosurgery. This is a lady with von Hippel-Lindau, came in an inability to swallow, had quadriparesis, and obviously this was this quote-unquote simple case with nodule and cyst. You resect the nodule and cyst is gone. One of the things that in analysis of this case, and I learned this from Dr. Almefti, look into every case, look into every picture. You see, here is vertebral artery. It's adjacent to the vertebral artery, which is good. It's not dangerous. You just need to know about it. And it kind of tells you how to do your dissection, find the vertebral artery, which is not very difficult with this exposure, and go there. And obviously drilling a condyle laterally about 1/5, 1/6 will help you get there. So as you expose, you can see here, first, of course, get rid of the arachnoid membrane, and of course, get rid of the dentate ligament, because that will allow your mobility. And again, doesn't matter big or small, there is a draining vein, and then there is arterial feeders. So you want to leave the draining vein till the very end. This is the draining vein, and you have to go around it. Now, this is a brainstem. Remember, you cannot go into the brainstem, and you cannot go into the nodule because it bleeds. So you have to find the perfect location where you'll open this PL junction between PIA and the wall of the nodule. And you see here, you are slowly progressing circumferentially. Vertebral artery is right here, and here is one perforator coming off the vertebral artery. So you got to preserve the perforator. You have to slowly dissect. And here I'm holding it for one of my residents to dissect and open and preserve the perforator and go further. So as we progress and open the cyst, obviously the cyst drains, as you can see here, and the whole situation collapses, and then keep going around and leave the vein till the very end. To advance further, here we are now at the 11th hour of surgery, not 11-hour length, but 11 hour in the terms of the end of surgery. These surgeries are usually about 1 or 2 hours, obviously not very long. Here, again, devascularizing, finishing. I'll speed up a little bit for interest of time. And then when we come to the very end, you have this vein, which goes at the end, and always finding the perfect plane not to get into the brainstem. Here is the vein left till the very end. And as you saw, this is, if you do it right, very, very vascular surgery. Here is the final part of it. And then basically removal. Again, you can see that doing partially transcondylar drilling, a little bit of the condyle helps you open the dura wider, helps you expose the vertebral artery and the perforators, and here is the removal of the tumor. What was interesting, I tried in the recovery room to offer this lady who was completely unable to swallow. I tried to offer her breakfast, and she was able to swallow without any problems. And I'll show you one more case also I published in Operative Neurosurgery. This is a spinal thoracic hemangioblastoma. And a lot of people are scared of these locations because, as you see, the nodule is taking approximately 80–90% of the circumference of the spinal cord. It's very critical location, lower thoracic spine, obviously. And then you can see here the big cyst around the nodule, and then syrinx going all the way up to the brainstem. So when you open, obviously, we open the dura, keep the arachnoid membrane, tack it. You can see here, Liga clips. I like to have my planes and know exactly where we are. And this is a mess. You see, you don't know anything. Where is what? You can see here cauda equina nerves. You can see here contribution of the Adamkiewicz artery. And then what you do is you start slowly dissecting. The worst case scenario is go into this vein, go into this arterial, and cause a disaster in this small area of spinal cord, lose the planes, and basically lose precise resection of the tumor. So you go slowly at the border of the nerves and the nodule, and I come around as I did in any other location. So location really doesn't matter. They all play the same game. You got to take the arterial contribution slowly, meticulously, take your time, and then keep the vein till the very end, and then remove everything. That way you'll have a vascular surgery for the most part. And as Professor Yashagil taught us, just go slowly, devascularize, and come around. So here I am on the top of the nodule, trying to find the plate with the opening spring of my bipolar. You see preserving the arachnoid and PL plane on the blood vessels, and slowly, slowly progressing towards the inferior portion of the tumor. Here I have released the tumor superiorly. I'm going now to release the final right lateral upper aspect of the tumor. And then obviously we are going to leave the vein. And here we have gliotic tissue right on the top of the nodule. Of course, SSCP, MEP, D waves we use on every case. And then we also like to use micro instruments, controlled suction, Yashagil bipolar, all the routine things that we use always. So coming to the very end, devascularizing the last parts of the arterial contributions. Always, if you have some blood that kind of pulls down, you want to see the glistening area of the spinal cord, because that will give you a good plane, and that will give you a good feeling of the nodule. As the dissection progresses, the nodule is more and more isolated, and then at the end of the day, you have a killed, devascularized nodule, like we have had in the brainstem or anywhere else. And at the end, you come here to the main draining vein, coagulate it here, and remove it. So this is the final picture. I approximate the best. I can the arachnoid membrane watertight closure of the dura. This is very important. Gel foam powder is a savior, and it really obliterates gel foam powder balls. It works great in cavernous sinus, and it works great in pituitary surgeries, and it also works great in spinal cord locations. I just wanted to show you one more thing here. You see, here is the fat that I obliterate the epidural space. You have to do it the right way. You don't want to overpack, you don't want to underpack, but again, this will save you a lot of trouble and prevent spinal fluid leak, possible meningitis, and so forth. So here is the patient coming for stitches. Obviously, his urinary retention resolved, the syrinx resolved, and I'm going to stop here. I hope I didn't go over the time limit. I'll be very happy to ask any any questions.
Thank you very much, Kenan. Yes. Let me ask you, I don't know if there is somebody want to ask something, Paulo Cádio, Juan Luis Gomes Amador, or the people, Gustavo, the people that is here watching about the hemangioblastoma. In syndromic patient, that we have one in the posterior fossa and one in the spinal cord, how you decide to operate the spinal cord hemangioblastoma? If you just find in the screening, you find one posterior fossa, one in the spinal cord, asymptomatic. You think you should do, should treat, should wait, should irradiate? What should you do? This is spinal cord hemangioblastoma asymptomatic.
You asked me all the question in one great question. So first of all, I obviously look at the patient, analyze the pictures, and decide if the tumors are symptomatic or asymptomatic. Obviously, majority of patients I see are symptomatic. They come for surgery because they already, somebody vetted them, decided that they have urinary retention, paraparesis, inability to swallow, gait problems, and so forth. If I find the lesion that is asymptomatic, and I have several, depends, of course, location, size, symptoms. It's fully asymptomatic and lesion is small, you can afford to wait. But you have to really be careful. If they are syndromic, you need to look into all other aspects. Where do they have tumors? If they have renal cell carcinoma, retinal hemangioblastoma, things that can make them bleed and die, or metastasize, you want to address those first. The other thing is also, you look at the age of the patient. It's not the same if you have young patients, the lesion will definitely grow. And in that case, you have to operate, because it's better to operate when it's 0.5 centimeter, 1 centimeter, than 5 centimeter in size. So age is also makes difference. Syndromic cases. If there are multiple location, obviously you base your decision on the size, symptomatology, and all that. So judicious approach, evaluating the patient, analyzing the images. That's how I do it. I don't know how. Juan Luis, what do you do? Do you operate all of them? Do you wait? Do you do a little bit of everything like me?
I don't know. I'm asking for you.
So that's what I do. I kind of analyze case by case. And many times, Louis, syndromic patient, you're right, that they're hemangioblastomas. But non-syndromic patients that you saw are more common in supratentorial, infratentorial locations, you don't know for sure that they are hemangioblastomas. And they appear with very nasty pictures and a lot of edema. And you also think this may be a metastasis, that may be, glioblastoma of the cerebellum, all kinds of different things.
Yeah, my concern is about the spinal one, that you find one asymptomatic, that this tumor will grow, that you become symptomatic, and it's much easier to do the surgery when the tumor is very small, when the tumor is large, especially in the spinal cord. In the posterior fossa, if you find one cyst and the nodule, you can go there and take it. There is one question here, Dr. Daniel Babu, but now it's difficult. Something like that. I cannot understand. Asking, what's the clue to diagnose of hemangioblastoma in MRI? What's the main find? Is if there is different in approach when it's solid or solid cystic. I think he's asking about the cystic, if you need to remove or not the. So
first of all, we need to know that there are 4 types. If it's single nodule with the cyst enough to take the nodule, don't touch the cyst, it will collapse. If it's solid or combined, as I showed one case, cystic and then solid, you gotta come around the tumor, devascularize it, take it out. So approach is completely different. So one of the reasons I did this study on different types and how often do they appear is for people to understand when you analyze what to do. It's not one size fits all. It has to do with a decision on case-by-case basis. So as I said, for example, the one that I showed that is cystic and solid combined, you cannot go into the cyst because you'll be in the middle of the tumor. You'll have huge bleeding. You have to come around, take it out, and cure the patient. So again, the spinal cord, I absolutely agree with you. If it's smaller tumor, even if it's asymptomatic on younger people, as I said before, younger people, you want to operate when they are small, or you can follow just very short time and 1 millimeter increase, you proceed. Of course, some people, come and say, oh, I don't want surgery, I want following. Absolutely. And some people say, take it out. So there is psychological differences between different patients. So I hope this answers. Professor Kadri.
Yeah, please.
Thank you,
Go ahead, Paulo.
thank you, Kenan. Always very beautiful, very, very amazing cases, and we always learn so much with your experience. So I have a question, especially in patients with von Hippel-Lindau disease, that after you approach that you may have to come back at one point because of de novo tumors. Is there anything that you do to prevent the adhesions and maybe to facilitate your dissection if you have to go back years on the road?
Yeah, that's a great question. I have several patients with von Hippel-Lindau that I operated, and 5 years, 10 years later, you start finding a small spot somewhere else. So like in any brain tumor, even in meningioma that I'm sure that I gross total resection grade 0 Simpson, I follow them for life. I don't follow them every month. I don't follow them every year, but maybe every 2 or 3 years. So you have to follow them. That's the first answer. Follow them for life. And decide about the length of follow-up based on, their age and all that. Do I use any specific foreclosure that they tend to come back? In my experience, they don't tend to come back exactly at the same location, maybe a little bit away, because you took that nodule, and obviously I don't have hundreds of cases, just a few dozens, but I think what you need to do in the spinal location, you have your arachnoid, you can bring back arachnoid, as I showed I preserved, and you can coagulate it to preserve some sort of arachnoid reconstitution, or even some people suture it with 8-O-proline and then close the dura again over it. So the best possible prevention of adhesions that you can do intraoperatively. It's very difficult. Cerebellum also you can try, especially in the craniocervical junction. You have a good arachnoid plane which you can preserve and then close back. Cerebellum supratentorial, not that much, because obviously there you don't have that well-established arachnoid. But I think important is to follow them up for forever, because even after 5-10 years, they can show up a small nodule. And I know there are a couple of patients that I'll need to operate. I saw a small nodule, 2 millimeters, then become 3 millimeters. And I'll probably, as they come to 5 or 10 millimeters, come and take them to surgery.
Yeah. Byron, want to ask something? Or Juan Luis?
First of all, congratulations to Professor Cannon, an amazing lecture. And for us, the young neurosurgeons, we learned a lot. We watch your technique, and thank you for that. Just one question. When you go, for example, in cerebellar hemangioblastomas, do you like to go through the sulcus or maybe through the cortex? Because I have sometimes noticed that when you go through the sulcus, maybe you have a little bit more of bleeding. Maybe it's a little difficult to control. I don't know. What's your experience or your recommendation for that?
So when I operate on these tumors and any tumors, of course, first I like to do wide exposure. I don't like, this is not the tumors that in cerebellum you'll do minimally invasive. You want to expose whole hemisphere of the cerebellum. You want to know where is your transverse sinus, sigmoid sinus, and all that. Second, you have your neuronavigation where you have exactly location and you map out the tumor. Third, sulcus or cortex, they all have cortex. Gyrus and sulcus, they all have a layer of cortex. And so I think what you need to do is find out that location, where is the best position to entry. What I like to stay, as I showed you, stay away from the draining vein. And then you need to, as I showed in this brainstem location, you need to find that perfect spot where you're not in the healthy brain or brainstem and you are not in the lesion. So you have to find that perfect location where you will enter the do the corticotomy and coagulate those blood vessels. There is always 1 or 2 millimeters you want to allow. As I showed, again, I'm emphasizing these are not like AVM blood vessels that you dissect the blood vessel, go up and down, coagulate, cut. These are more lakes contributing. So that's what I do.
Thank you, Professor.
I think Professor Juan Luis, please go ahead.
So
You're
Your
muted.
microphone. Yeah, good.
first, I want to thank for this great evening or night for you. I think we have learned about the microsurgical technique. And there is a point of controversy when we are dealing with the use of exoscope, or as now they call the digital microscope. Because as Professor Boba said, it is very ergonomic to use, and it facilitates in some cases, especially, for example, for pineal region tumors, the ergonomics of the surgeon is better. And the other important thing that I have enjoyed a lot this night is the concept of Professor Arnautovic using microsurgical dissection and using this special bipolar forceps in order to dissect and identify the vessels that go inside and go out of the hemangioblastoma. This is perhaps a very good lesson of microneurosurgical concept and enables us to perform a radical lesionectomy. It is very important to address that in the hemangioblastoma, the surgery must be complete, because otherwise the lesion will come back some years later. So I have enjoyed this a lot, and I thank you very much for these great lectures.
One more thing
Thank you.
here. One of the questions was how to differentiate hemangioblastomas with the solid part from pilocytic astrocytomas. So that's a good question. As I mentioned, one of the luxuries I personally have also, for full disclosure, I have neuroradiologist on site in my department when I have a clinic and also in the hospital 24 hours. So I always can call him and go over the computer or personally. And they are really smart. One of the things that I noticed in hemangioblastomas as opposed to pilocytic astrocytomas, they like to live close to the transverse sigmoid sinus. They are always in that area. They are not away. Pilocytic I have seen everywhere in different places, but these hemangioblastomas, they are close to major blood vessels. That's one of the things. And then obviously the type of the cyst. I think pilocytic may have different content of the cyst. Hemangioblastoma, very clear fluid. I think pilocytic tend to have a little bit differences on flare or some other sequences. So these are a few tricks to differentiate.
Yeah, one thing that is important to differentiate hemangioblastoma and pilocytic astrocytoma, first is the age. The pilocytic astrocytoma is typical from the childhood. If there is an image very similar to that, hemangioblastoma in children generally is syndromic, is not the isolated. The hemangioblastoma generally is in adults, but in children can be inside syndromic way. See, I don't know the image as Kenan said, but I think it's important to understand that they are completely different disease, and the population will be different. And in children, it will be more syndromic when you have hemangioblastoma than they really isolate hemangioblastoma. In a very simple way to sometimes to see this is syndromic or not, just do a blood test. See how much you have the how you say the hematócrito. How you say, Paulo? You know English very well. Como que se diz hematócrito? Oh, Paulo Cade spent 5 years in the US. His English is worse than mine. Go ahead, please. My wife is saying,
I was trying to unmute. You saw
is global what? Global what? Huh?
The blood cells count.
No, nothing.
Is
that?
Increased red blood cell count. Increased red blood cell count.
Okay, now
you know, one thing, Paulo, here I need to get you on the record. You know, I didn't get the book of Professor Borba signed. I'm really hoping that I'll get at least the brainstem book from you as a friend.
You'll get it for sure. That's the problem.
The problem now, nobody is buying my book. My book, our book. Because there is a PDF in everywhere.
You got your own number of books and you can distribute it, but I'm waiting for my copy. I'm just kidding.
I send one for you next time that I meet in South Africa. Okay? Okay, now it's 9 p.m. in Brazil. What time is in Memphis now? 7 p.m.?
6:41.
6:41. Okay. Time for dinner. And for us, you continue here later with our team here to discuss some case.
Thank you so
very
much.
Thank you, sir. Thank you, John.
Thank you, everyone.
And maybe in 15 days, you come back. Next week, you have the Brazilian meeting. And Paulo Cade also want to announce something that is very important for the next year. That we have a good news that for our friends and colleague. Please go ahead, Paulo.
Thank you, Barbara. So I'd like to invite every one of you for our 32 course of the skull base. It's the Almefty course in St. Louis. It's the most traditional of the skull base courses. And this year, we'll have exactly our Professor Kenan Arnautovic as our honor guest in St. Louis. And as you see, he will also contribute with some of his beautiful experience and dissections. So I wait for all of you over there. Thank you.
You have the dates already?
It's April 30 to May 2nd.
Okay. Let's make the flyer. Let's make the flyer you can send to everyone. Let's meet everyone there. And Professor Kenan also meet you. You pay a very nice dinner to everyone. I know.
Always enjoy meeting you all, guys.
Okay. Thank you.
Yeah, Louis, I want to make a quick announcement for speaking of skull base that you're going to speak at for Samuel.
Yes, I'll be there.
Yeah, on October 14th and 15th. I believe Dr. Kadri is also speaking there. We'll have all the top skull base surgeons. So we hope to see you there, the 14th and 15th.
24 hours per day. We have 200 speakers.
Oh, it's going to be a huge.
Yeah.
May I say something?
Go ahead.
Professor that is organizing, you know, he's a vice chair of the oncology committee, Sameh El Morsi Hassan. And I noticed him 2 years ago. This is true story. And I noticed he's very energetic, very active. And he became one of the leading forces on organizing these symposiums, I think in the past 2 years, not only as a vice chair of oncology committee, but he organizes all kinds of symposiums. He learned the tricks, he learned the techniques, And I think what we need to do, Luis, invite him to maybe give a lecture how to organize symposiums, because, you know, there is a tricks how to do it. I have no idea about that computer stuff and how to announce, how to put everything together, how to put time slots, how to put alphabetical order, run it whole day. And now he's daring more and more. He's now doing 2 days, 3 days, 150, 200 participants. It's crazy how good he is. He's a treasure, and we need to keep him and learn from him. So
he's very
kudos
active,
to Professor Sami El Morsi Hassan.
Yeah, he's very active and very good man. Very good man.
Doing a lot of work.
Okay.
We'll see you in
See you in
a couple weeks.
15 days. Bye-bye. Thanks, Kenan. Thanks, Paulo.